Okay guys, so since I can't be with you today, I'm going to give you some of my notes, and hopefully you will have these to review for your test next week. So I'm starting, as you can see, in Clayton chapter 22 and ATI chapter 23, and they are about anti-lipemic agents, drugs used to treat dyslipidemias, basically high cholesterol agents. So remember that cholesterol is a naturally occurring substance. It's used for synthesizing body steroids, used in the endocrine system for synthesizing bile acids that are needed for food absorption, and for synthesizing cell membranes. The body is able to synthesize enough cholesterol to meet its own metabolic needs. However, the body converts excess dietary cholesterol into, excess dietary carbohydrates into triglycerides, which eventually turn into cholesterol, and excess dietary fats into cholesterol, and eventually all that excess dietary fat and cholesterol turns into fatty plaques in our arteries and turns into those fatty plaques that clog up our arteries, and that leads to atherosclerosis, those plaques in the arteries, which will narrow the blood vessels and lead to poor circulation, which can cause heart disease, coronary artery disease, MI, and all those bad things that come along with that. So anti-lipemic agents look to decrease the level of cholesterol in the body. The cholesterol in the body the molecules are bound to proteins, what we call lipoproteins, and they're found in 5 different types. Remember, lipids are fats, so when they're bound to proteins, we call them lipoproteins, and there's 5 different types. The 2 types that we're most concerned with are something called high-density lipoproteins, or HDLs, and low-density lipoproteins, or LDLs. There's a whole lot of information available out there, but basically keep in the back of your mind that high-density lipoproteins are what we commonly call the good cholesterol. These are the ones we want. We want our HDLs to be good. These are our good cholesterol, so we want those to be high. And the low density lipoproteins, those are the bad cholesterols. We want that to be low. So we want low levels of those low density lipoproteins. So these anti-lipemic agents are aimed at lowering the levels of LDLs in our bloodstream. So drug therapies for hyperlipidemias, high levels of these lipids or cholesterols in our bloodstream, the primary drug treatments fall into 3 categories. So 3 of the categories we're going to talk about include something called bile acid binding resins. And these are drugs that will actually bind the excess cholesterol and make them inactive. They kind of suck them up, make them inactive, and then they're excreted through the intestine. Niacin. And then something that we call statins, which are the most common ones. Their long name is HMG-CoA reductase inhibitors. But we shorten just to call them statins. So these are the ones we need to know right here. These are the categories that we're going to talk about. Okay? If you look at page 346 in Clayton, There's a paragraph titled Nursing Implications for Hyperlipidemia Therapy. Read that over. That gives you some information about nursing considerations. So look at that. I'll let you read that over. And we're going to talk about each of the classifications individually. So I just updated my picture here. So the first one we're going to talk about is bile acid binding resins. Sometimes they're called sequestrants. And basically what these do is they form a non-absorbable complex with bile acids. So they form a non-absorbable, that should be an A, complex with bile acids. What this does is it causes the liver to basically produce more bile acids, which causes the liver to produce less cholesterol. So in a roundabout way, the liver decreases its production of cholesterol. The most common drug is Questran, and I have to look up how to spell this. Cholestyramine. This drug name always reminds me of styrofoam. I always think of this drug as styrofoam. And it commonly comes in a powder form, but it may also come in pill form. A couple of things to remember about giving this drug. It may come, like I said, in a powder resin. Some adverse effects. Most of the adverse effects with this drug are GI. Because it's basically absorbing all this excess stuff going on, it's causing, think of it as kind of soaking up all this excess bile acid and cholesterol. It's going to bind the person up, so it's going to cause constipation. It's going to cause fullness and bloating. Nausea, flatulence, let's see what else. It has some significant drug interactions. Because it is binding everything else, it can also bind drugs. So think about it, if it's binding all of these cholesterol molecules, it's also going to bind drugs and make them ineffective. So things like digoxin, warfarin, which is Coumadin, thiazide diuretics, phenobarb, NSAIDs, beta blockers, oral contraceptives, these will all be inactivated by this drug. So be very aware and make sure your patient knows when taking this drug that this is a concern. Some nursing considerations. Make sure your patient drinks lots of water when taking this drug. Do not try to take the pill dry or try to take the powder without water. Encourage water afterwards. I'm just going to write encourage PO fluids. I'm going to pause for a second here. All the drug interactions, meds should be taken 1 hour before or 4 hours after the drug. That gives the drug time to get out of the patient's stomach and small intestine, and gives the other drugs time to pass through their system. Okay, and I think that's about it. They will cause constipation. Again, encouraging fluids and fiber in the diet will help with that, along with all those things you learned in fundamentals, ambulating your patient, encouraging mobility, all those kinds of things. That will help. Oh, I can't spell. Sorry. A little eraser here. Okay, so I'm going to pause here, clear the screen, and then we're going to move on to the next category of drugs, which drug for this dyslipidemia, which is niacin. Okay, so the next category we're going to talk about is niacin. So I wrote out most of the notes here. I'm just going to highlight a couple of things in red. Niacin is actually a water-soluble vitamin. It's a B vitamin, vitamin B3, but when taken to lower cholesterol, it's taken in much larger doses than as a vitamin supplement. The mechanism of action is not well understood, but it does cause a decrease in those LDLs, those low-density lipoproteins, and triglyceride levels, and it reduces the metabolism or the breakdown of the HDLs, the good cholesterol. So it decreases the levels of the bad cholesterol, and it raises the level of the good cholesterol. So it's kind of a twofer. It helps in both ways to balance out our cholesterol levels. It is a low-cost option, so it is a benefit compared to some of the other drugs. However, it does have some pretty significant side effects. Niacin causes a release of histamine, and histamine causes vasodilation. And with that vasodilation, there's an increased blood flow to the skin, so it causes a significant flushing of the skin. But if that vasodilation is severe, it can lead to hypotension. There's a significant reaction that occurs with niacin called red man syndrome. If you look up niacin reaction on the internet, you'll find red man syndrome along with that. It's pretty significant, and it has to do with that histamine release. GI distress goes along with most of these antilipidemic drugs. GI distress, nausea, fullness, constipation. Usually they're self-limiting. You can have the client take the medicine with food. but they should expect those kinds of effects with these drugs. Hyperglycemia, this one is unique to niacin. You have to watch the patient's glucose levels. They don't recommend niacin for diabetic patients. For this reason, their blood sugar levels will be difficult to control because of the niacin. Their blood sugar levels will continue to go up. Hepatotoxicity, so if the patient is at risk for liver problems, or if they have a history of liver problems or alcoholism or hepatitis or liver cancer or things like that, you should not use this drug for those patients, and monitor their baseline symptoms. And hyperuricemia, uric acid crystals can accumulate in the blood. If the patient has a history of gout, that's where the uric acid crystals will build up in the joints. This could be a problem for that patient. Patients should be encouraged to drink plenty of water to eliminate that possibility. Lots of water to eliminate that. And that's really it. There's not a whole lot going on with niacin. The biggest thing to remember with niacin is the fact that there's this release of histamines, and that it's a vasodilator, and that the possibility of hypotension and the increased blood flow and the flushing of the skin is the biggest problem with it. Okay? And the last group of drugs I'm going to talk about is the statins, and that's the most common one you're going to see. So I'm just going to pause here for a moment and we'll work on the statins. Continue on with the statins. Like I said, the long name for these guys is HMG-CoA reductase inhibitors. We commonly refer to them as statins because their generic names end in statin. I put a list over here on this side. You can see the most common one you've probably heard of is Lipitor. The other ones are Zocor, Mevacor, Pravachol, Crestor, Lescol. Lipitor and I believe it's Lescol. Yeah, Lescol down here. These two drugs are approved for patients with renal disease. I don't know that that's going to be on a test, but you might just want to make a note of it. The others are not approved for patients with renal disease. So that's just an aside. The statins are great drugs for lowering cholesterol levels. They are the most potent anti-lipemic drugs that we have. They are also the most expensive. They work by increasing the production of our good cholesterol and decreasing the production of our bad cholesterol. So they are very potent, but they are also very expensive. They also help to promote wellness in the vessels that are affected by atherosclerosis. Remember, the vessels that are being clogged up with all the cholesterol is forming all those plaques, and the blood is having a hard time getting through. So these drugs help with vasodilation. They help to decrease inflammation where the plaque is. They also decrease the risk of that plaque breaking off and forming an embolism. So that's what I have written here, all those other benefits of these drugs. So they promote vasodilation, decrease inflammation at the site of the plaque, and decrease the risk of thromboembolism. So some of the adverse effects of these statins, hepatotoxicity is a big one. So some of the things you may see with hepatotoxicity is anorexia or decreased appetite, vomiting, nausea, jaundice, dark-colored urine, and then increase in liver function tests. Before you start a patient on these drugs, you definitely want to get baseline liver function tests, and then have the patient observe for any of those symptoms, and definitely call the provider if they see any of these things going on. The client should be told to avoid alcohol. So I'll go ahead and just say going on with my pen here? Advise the client to avoid alcohol. ETOH is alcohol. Okay. And then tell them, if their liver function tests are going to be monitored periodically while they're taking the medicine. And if they come back abnormal, they may be taken off the medicine because they can be toxic to their liver. Myopathy is another one. Remember, myo means muscle, and pathy means disease. So myopathy is when the muscle starts breaking down, and this may be displayed by muscle pain or weakness. And this can progress to something called rhabdomyolysis. And that's when there's an overwhelming breakdown of the muscle tissue, which can actually lead to kidney failure. And that's very, very serious. The patient is at risk for complete kidney failure at that point. The patient will need to have something called their CK level checked, which is their creatinine kinase level, creatinine kinase level checked, and it will need to be monitored periodically while they are receiving treatment. They will need to have it monitored periodically. They will need to tell the provider immediately if they have any signs of muscle pain or weakness, because that is a very serious side effect. So that's an important thing to remember, to tell the patient to monitor for those things, muscle pain or muscle weakness. And they need to be taken off the drug immediately. Interestingly enough, simvastatin, or Zocor, up here, Zocor, has been shown to cause a higher incidence of myopathy and rhabdomyolysis in Asian patients. So it's been contraindicated, well, not contraindicated, but used cautiously in patients of Asian descent. And these drugs are contraindicated in patients who have hepatitis and who use alcohol because of the hepatotoxicity and myopathy. Their liver and kidneys they can't handle these kind of drugs. And the last one down here is peripheral neuropathy. So weakness, again, numbness, tingling, pins and needles, pain in the hands and feet. Those kinds of things need to be reported to the healthcare provider. All right, so those are some of the adverse effects. And these drugs, I wrote down here, these drugs are pregnancy category X. They should not be used at all in pregnancy. If the patient becomes pregnant while taking them, they should stop taking them immediately and report to their provider. All right, so I'm going to pause here for a moment and then talk about some of the interactions and nursing considerations. To finish up the statins, some medication and food interactions. Erythromycin and ketoconazole. Erythromycin is an antibiotic. Ketoconazole is an antifungal agent, and grapefruit juice. These three things right here will all increase the level of statins. So the problem with increasing the level of statins is they put the person at risk for toxicity. And remember, adverse effects of statins include hepatotoxicity and rhabdomyolysis or myopathy, which can lead to liver failure and kidney failure. So that's kind of a big deal. So grapefruit juice should be avoided. Patients, they don't have to cut out grapefruit juice altogether, but they should not drink more than about 8 ounces a day. And erythromycin and ketoconazole should not be taken while the patient is taking statins. Some notes about nursing administration for these drugs. This is an important point that I think a lot of students miss. These drugs should be taken in the evening. Most of the cholesterol in the body is produced in the liver in the evening hours, so these drugs should be taken in the evening. So please make a note of that. Somehow stick that in your brain. Remember to take these drugs in the evening, and they should be taken with food to minimize the GI distress as well as to help them work better. And they do cause a lot of disruption as far as liver and kidney functions. So baseline labs will be obtained, and then baseline liver and kidney tests will be obtained and monitored throughout the therapy. So that's just a couple of things to keep in the back of your mind. Make sure that the patient is taking their dose in the evening, preferably with their evening meal. That's the easiest way to take it. And then baseline labs, HDL, LDL, and their triglyceride levels, and then baseline liver tests and renal function tests, and they should be monitored throughout the course of their therapy. Okay, and I think that about covers it. That will cover all the way through chapter 23 in ATI and chapter 22 in Clayton.